I didn't really know what to do with it. Felt exposed. I felt like a failure, and I felt like I know how to do better. I just didn't do what was right. And the mom was right, and I failed to give her and her son what they needed.
Everyone in healthcare has a story they never forget. Some are beautiful, some are difficult, and most are never told. This is the space and place where doctors talk about moments that changed them. Welcome to HUMED, where we talk about the emotional, moral, and human realities of medicine. I'm Dr. David Spiro. Thanks for being here. Please hit subscribe wherever you get your podcast information. I'm incredibly delighted and honored to have Dr. Ben Jackson with us today. Ben is born and raised in Charleston, South Carolina. His undergraduate education was at Wake Forest University as a BA in history, which is interesting. He went then to the Medical University of South Carolina, a very prestigious medical school, and then attended internship, residency, and fellowship at the University of Alabama, Birmingham. So we are connected in that we both did our fellowship in Alabama and trained with the same people. Since 2009 to the present, he's now actually a professor of pediatrics back at the University of South Carolina, the Medical University of South Carolina. He's the director of Procedural Sedation, which we'll talk about some today. He's also the PEM Soul Care Faculty Advisor and Quarterly Wellness Processing Initiative for PEM Fellows, and has an interest in compassionate care, empathy, and sort of the softer side of medicine. Probably most importantly, he's married to his wife Elizabeth for close to 25 years. He has 4 children, ranges from 12 to 23, and loves to run, and has an interest in the outdoors. So Ben, welcome to the show. I'm incredibly delighted to have you share your story today.
Thanks so much. It's really a pleasure and an honor to be here. Thank you.
So why don't you go ahead and tell us what story you'd like to tell, and so the audience can learn a little bit about you through the art of storytelling.
Sure. So my story is sort of maybe the tale of 2 stories, the tale of 2 patient encounters that I feel like kind of benchmark my pediatric emergency medicine sort of niche of procedural sedation. I can unpack that a bit. Procedural sedation being the idea or the practice of having a patient who needs a procedure. Generally, procedures in kids are either painful, distressing, some combination of the two, otherwise unpleasant. And in the emergency department setting, we're really providing unscheduled care, right? These are parents or caregivers who've brought kids in for something they weren't planning to have happen today. In many ways, we get to encounter patients and families on some of their scariest days, on some of their most painful days, on some of their hardest days. Sometimes, in fact, I would say the majority of times, those encounters are able to be reversed and those conditions rectified, and patients recover, and we get to participate in that. We get to encourage, reassure. Sometimes we do some impressive interventions. Other times we're an ear, a place where problems can be solved, questions can be answered, things of that sort. But procedural sedation allows us to connect to our patients' needs when they're in periods of pain or distress and have to undergo a procedure. And so I had, as I reflected on this, a couple of patients that really sort of spoke to me and framed maybe what I needed as a young attending, that sort of challenged me. It was sort of a firm rebuke by some erroneous care or perhaps lack of care that I provided or failed to provide. And then I think a case a few years later, really where I don't know that it was just me. Certainly wasn't just me. I was the attending of record for the case, but where our team got it right and saw a patient, saw his mother, and connected and delivered what was needed. And I kind of hold my practice between those two extremes. The first patient that I'll tell you about was this otherwise healthy 11-year-old male. This is probably 2 or 3 years into my my career as an attending. So following all of my residency and fellowship training, as theoretically planed off and figured out what I was doing, knew what I needed to do for most patients, and knew who to call when I couldn't quite figure it out. I'd kind of understood how the system worked. And this happened to be a day with some degree of busyness, higher patient volume, and a relatively seemingly straightforward patient who had a soft tissue infection, an abscess, a boil on his back that was not so big, but it was intensely painful to him. And the pediatrician had sent him to our department to have this painful condition addressed. And as I worked my way through the shift, I had a very competent, very confident senior resident working with me. He went in and seemingly handled what was to be done. He connected with the mother. He assured me that this patient just needs a little bit of topical numbing cream and a heat pack placed on this, and doesn't need any procedural sedation to get through this. We have the plan worked out, and mom's good with the plan, and it seemed like relatively straightforward. So I sort of show up at go time for the procedure without having connected with mom and patient much on the front end, and seemed like we were ready to go. And what resulted was really, and I don't know that torture is the right term, but it was very, we didn't do a good job of addressing the patient's his pain really at all. Instead of putting on one type of topical anesthetic, an inexperienced nurse had placed a similarly titled alternative topical anesthetic that didn't work, and I failed to recognize that.
Hmm.
I failed to connect with mom and ensure that at least they knew kind of what this would involve. And I really just didn't conduct the orchestra, lead the team well. And so the mother interrupted the procedure, said, we're not moving forward with this. You can give us antibiotics. We can come back another day, and when you're not working, kind of a thing. And actually was brave enough, I think, to write me a letter through a patient care liaison, sort of rebuking me for the failure to provide adequate care to her son. And that was really, really humbling. You kind of get these communications infrequently, but certainly as a young attending, I didn't really know what to do with it. Felt exposed. I felt like a failure. And I felt like I know how to do better. Countless other times in the past, I've done better, but through sort of the set of circumstances present that day, I just didn't do what was right. And the mom was right, and I failed to give her and her son what they needed. And that was really a humbling experience.
So I'm curious. By the way, thank you for being vulnerable and sharing the story, because we all, and I, multiple times in my career, have received patient complaints for various reasons, and it doesn't feel good, as you said. So I'm curious, when this procedure was interrupted, was there a moment where you apologized to the mother, or what was what can you give us a little bit more detail about the interactions with the mother? Because we've learned a lot, and I know you know this, but we've learned a lot over the last 10 to 20 years and this wasn't a medication error, but when errors do occur, having a conversation and disclosing the errors, and having maximal transparency, reduces trauma for the family, and also reduces the incidence of a medical legal event. And both are important, but I'm curious what your interaction was with the family as this procedure needed to be timed out.
Yeah. I wish I could say I did it perfectly, right? I certainly apologized, for my failure and my what they received as sort of ineptitude, and that was humbling. I tried to present myself as humble and sorry. I don't recall specifically if I made the distinction between LMX cream and let gel, sort of a distinction that may not mean a whole lot to listeners, but perhaps one is it can be absorbed by sort of intact skin. Another more used for like laceration repair that needs to be absorbed through open skin, and the let the lidocaine, epinephrine tetracaine preparation was placed on this. I don't recall if I got into the details of that. Um, I uh, I apologized. I tried to convey my failure, and mom really just wanted it over for the day, and so in some ways I felt like I sort of sleeked back out of the room, feeling like I had done an insufficient job, both in rendering what was a pretty straightforward procedural care opportunity, but truly failing to render like compassion and understanding on the front end, and then to deliver the care I needed. And then I didn't feel like our communication was great, and that was a real learning point for me, that I try to hold in mind as I encounter these or as I've encountered these moving through my career.
Yeah, patients teach us things, and families teach us things. And I've learned, and I have some awareness at this point in my career of where my own limitations are. And I'll give you an example: is I have some frustration these days with children who smoke marijuana and come in with hyperemesis syndrome. And I'm sure you have this in
Sure.
Charleston, where they're repeatedly coming into the emergency department with vomiting, and they're sick, and they need IV fluids, and they need medication to stop their vomiting, and many times they need to be admitted. And I think one of the reasons why I went into pediatrics and pediatric emergency medicine is children are innocent,
Right.
but we also manage adolescents, which, by the way, I think is our most vulnerable population that we
Right.
manage on
Right.
many, many levels. And I have recently recognized my own internal lack of compassion on some level to children who, young adults, older children who self-abuse. But on some level, it is not completely their fault. But on
Right.
some level, at some point in the adolescent period, we also start to have to take children need to start taking accountability and responsibility. So, what how has that shaped you? Because you're actually the director of procedural sedation. Was this incident did it stimulate your interest in learning more and becoming better at it?
Probably at a subconscious level. I don't know that I like held this case specifically in mind. So, um, I would say early in my career, I felt well trained. I felt well equipped for the work of pediatric emergency medicine. A great training in University of Alabama, Birmingham, where you did your fellowship training as well,
Well,
and
who
came feeling like I was ready to go. And I feel like I was effective as best I could be as a junior faculty member. But you're right. Like, we have limits, and we're all we're all humans, number one, so we're prone to error, and we're all in process, right? I think the book knowledge that I had when I left fellowship and was sitting for boards, and I could tell you so many more right answers then that I could tell you now. And yet, I think in many ways I was arrogant, or had a more of like a sham or a facade of humility, perhaps. And I needed some of these kinds of experiences to help shape me. Um, I think your examples of a drug using or abusing older teenager has one way of looking at or offers one way of looking at things. But this was an 11-year-old male who hadn't done anything wrong to get this painful situation. And so, like, I really, we know, obviously we would say whether they're bringing upon themselves or not. They're our fellow humans. They deserve our compassion. They're worthy because they're our fellow humans. And someday we're going to be that patient. Someday we're going to be the beneficiaries, hopefully, or at least the recipients of medical care. And it's a real privilege to be able to care for them. And so that's what I would have articulated even then about my patients. But I needed this, I think, sadly. He suffered, and it wasn't longstanding pain that he suffered, at least from a physical pain standpoint. But I may have set himself up. I may have set him up for future, aversion to healthcare. I may have caused some PTSD for him that he's resistant. I don't know. That's one of the downsides of our work in the emergency department is we often don't know either the good we do or the bad we do. We just know if they come back and our colleagues saw them. And let me tell you about that kid that you saw the other night. And that's like the scariest lead into a conversation, right? Is that we missed something, that we failed somebody, that patient is now in the ICU or whatever. And that's a scary road to walk. But I think in many ways, as a younger, more junior provider, needed to be humbled and kind of needed to walk in that path. You mentioned my role as director, so some of that, I joined a relatively new group, not hadn't been established for a long number of years in Charleston when I showed up in 2009, and so we had some gaps in the and sort of addressing matters germane to our practice, and the relationship with anesthesia and sedation oversight in our hospital system was a gap that I had the bandwidth to fill, and it was a part of practice that I enjoyed in fellowship. I mean, I often say, and it sounds somewhat cynical, but in some ways I mean it, and it seems only more and more true that as we practice medicine with increasing utilization of technology, I find oftentimes that physicians are the ones taking care of computers and nurses are taking care of patients. And procedural sedation gets us to the bedside of patients. It allows us to utilize what we know about risk assessment, risk stratification, patient history, what this procedure is going to be like, pharmacology, what the medications are going to do, the patient's physiology. It requires us to communicate. It requires us to work as a team with nurses, with residents, with procedural consultants. Oftentimes we are providing sedation for procedures that are going to be performed by either colleagues or by consultants outside of our discipline. And so all those things are attractive to me. I think pediatric emergency medicine allows us to interface with essentially everybody in the hospital to develop degrees of proficiency. Sometimes I feel like we wade sort of ankle or knee deep into certain subspecialties or competencies, and sometimes I'm sure we find ourselves over our heads with what we're called upon to try to handle or try to navigate. And so I sort of moved into this kind of directorship through attending meetings and trying to solve problems and trying to address and level up our group's competencies in sedation and working through simulated scenarios and developing some educational curriculum, some based on what I learned and some based on what I gleaned from involvement in professional society work, and educational conferences that I attended, and just talking to people who were facing similar challenges, folks whose names are all over all sorts of publications who were available to me, like responded to emails that I sent more quickly than I respond to sometimes my colleagues or my family, and so I found it to be a very rewarding, sort of a collegial subset of pediatric and emergency medicine providers. And so they were the people that I wanted to be like. And I hope that as I've grown in this through plenty of errors and plenty of missteps, and plenty of experience and plenty of lessons learned, and I think some real successes, that I'm becoming like some of those legends and folks who had space for me, and that's at least what I would hope. And so that's the role I hope to play with our trainees as we sort of talk about not only like what do you put in a syringe and what do you connect to a hub and how you push the plunger, but what do you need to consider? What's going on with this patient? Is there a way to troubleshoot this without this approach or that approach? Or, how are the parents? How is the kid responding to things? Can we engage our child life specialists to help developmentally assess and connect with these young kids who are they're already scared, they're already hurting in many instances, and then we have to do something to them, ideally to make them better. And I have found that to be very rewarding, and so I feel like the realm of procedural sedation is really like a tangible means of rendering compassion,
Hmm.
of stepping in sort of the gap to be moved by a patient, but also to act on that sort of uh, recognition with a desire to alleviate pain, to render them in a state beyond that pain. And am I 100% successful? Of course I'm not. But it's sort of this worthwhile, but I think probably elusive goal to have the perfect procedural sedation encounter. But it's a continuously rewarding part of the work of emergency medicine that it really is life giving.
I appreciate that. I've really never thought about procedural sedation in the way that you described it, and it's really interesting, and it's really the the multifaceted way that you describe it is is just illuminating. I want to get back to this case and the fact that we take care of boils or abscesses quite frequently in the emergency department. When I started my career over 30 years ago in pediatrics, then peds ER, we didn't have a lot of boils and abscesses that presented. It's been much more frequent over the course of the last few decades because of overprescription of antibiotics and because we've developed resistance to certain things and the higher prevalence of certain forms of staph species, or what we call MRSA, or methicillin-resistant Staph aureus. And I'm assuming in your career as well, you've continued to see increases in these cases. But boils or abscesses have always been a quagmire for me, and I want to talk about this for a second because many times we sedate children because they have a fracture. They have a distal radius fracture, and it's angulated, and it needs to be straightened out by either us or by orthopedic surgery. And it's obvious that they need to have a procedural sedation to be relaxed and not aware of what's happening for these situations. But abscesses and boils are sometimes challenging because they're very superficial. And as you described with this patient, they could be very, very painful. They're oftentimes in sensitive locations, such as the genitourinary areas. And I sometimes have not had great success with topical um, or creams that we put on the skin over the boil, because what we have to do oftentimes, for those of you that have never done it, we have to open it up and then we have to actually express a lot of the pus or the fluid that's in there to get that out, which is part of the treatment, and then relieve that pressure that exists. And oftentimes just relieving that pressure reduces the pain, but the but coming near that skin and manipulating that area is incredibly painful. And I'm curious what your approach is, being a procedural specialist in our field, to boils in 2026.
Yeah. It's interesting. I don't know how the microbiology has evolved in Arkansas or elsewhere where listeners may be. I feel like we saw a really rampant or really crazy spike in this. I don't know. I finished my training in 2009, so maybe like 2007 through the mid-teens, maybe even into the late 20 teens, and have not since maybe since COVID, 2020-ish, seen the numbers, at least at our institution, that we were previously seeing. But that's just an aside. The point is
It's
taken that
actually not an aside
uh,
because I was teaching yesterday. I was actually in the PZD and we had a kid with a boil. And that point actually came up, what you just said, which is myself and one or two of the other attendings like, you know what, we're seeing less of this. And we were postulating in the ED yesterday that potentially, because of the public health campaigns, I'm sure that exists in South Carolina and in Arkansas and in Oregon, where I used to practice, there's been a lot of education for physicians to be more judicious about prescribing antibiotics. And I wonder, I don't know if there's any literature on this, but I
yeah,
wonder if that has actually affected the rates of MRSA in our communities.
I'd like to think that we've done a better job, and being more judicious. I mean, antibiotic stewardship is a big sort of topic in hospital systems, and ours is no exception to that. So I hope that we've done a better job. It's interesting. It feels like in the last 5 years, we've experienced a shift where, I mean, certainly every virus and cause of fever. It's probably hyperbole, but so many more people want test proven answers to whatever's causing their condition. Um, Patient satisfaction has been pursued, sort of this elusive, like, can you get the perfect patient satisfaction score? And so I don't know. I hope that we're doing, maybe we're communicating better. I hope, and we're connecting with patients and families in a communication in a human sense, and explaining why we might withhold antibiotics, but we still have high degree of concern and regard for your child. So hopefully that is working, and so that I don't I would I don't think I ever saw, like, here's your prescription for an antibiotic. I'm not talking to you. Get out of here. It's probably a virus anyway. I never quite saw that degree of overprescribing, but I think you're right that there have been very effective, seemingly effective campaigns to reduce unnecessary prescriptions, to utilize shorter durations of therapy, or hey, here's watch and wait for an ear infection that may have previously gotten 10 or so days of an antibiotic, that for a condition that may have spontaneously resolved. So I don't know, but I think that it is interesting, right, to see how things change. Um, but to the point at hand, it is right. You're right. I mean, like, these abscesses, these boils are intensely painful, and I think um, in my sort of junior, trying to be an academic era, and in the era where we didn't provide as much sedation as this, I think previously, for these painful conditions, where we would often, like, give somebody an oral analgesic, and then we would use, like, some freezy spray and lance it. I think we caused a lot of unnecessary suffering in kids at times in our past, and I can only speak to kids because that's the work that I do. And so there was an article at some point in the early aughts and mid aughts, at some point, of LMX may enhance spontaneous drainage of an abscess. I think I read that somewhere, and so we would combine topical numbing cream with a heating pad, and maybe that combination would cause a nearly ripe boil to spontaneously rupture, and you could get stuff. But as you said, like, I have not been as convinced that's a sufficient solution, right? A lot of these things are track, and they have loculations, then they need to be more aggressively managed. And so I have found, just seeing some of or a lot of these very pesky skin and soft tissue infections have involved, to truly care for, like I wouldn't want to be aware, and experiencing that degree of proceduralizing, of intervention, painful intervention. So I think it is a compassionate, as long as you can ensure safety and you're attending to all of the patient's needs, and we can ensure that the patient's otherwise safe. That sedation seems like a compassionate way to. I mean, it's sedation slash analgesia, right? We're not just altering their mind; we're addressing their pain as part of this. Um, but I would distinguish it, and I think it's appropriate to distinguish it from general anesthesia, right? These patients, that we're providing procedural sedation for in the emergency department setting, they're spontaneously breathing. We're not inducing a state of general anesthesia where they're completely reliant upon us to breathe through them through an inserted endotracheal tube or laryngeal mask airway. We're taking advantage of the pharmacology of these medications and the patient's own physiology and sort of innate health status to render a state where they're unaware, where they're uh, free of pain, or at least not processing pain if they're dissociated with an agent or two that we might use, where they're not processing pain in the way that we would conventionally perceive pain, and then we are fortunate that a lot of these agents can induce a state of amnesia, right, where they don't recall. The patient doesn't recall what was happening during the window of time that the patient was under the influence of that medication. So we're really privileged to have this pharmacologic technology, but I do think procedural sedation should be conceived of as more than just medication and what it does to the patient. I think it's more of almost like a culture, right? A culture of compassion that includes multiple disciplines of providers, that includes input from parents, that includes these amazing child life specialists who are undercompensated for the amazing work that they do, and who just love helping kids through distressing situations. I think all of it really frames procedural sedation at its best.
Mhm. It's interesting. I see sometimes, because I'm a pediatrician and so are you, and a dad, and so are you. I sometimes see the world through children's books and sort of literary figures. And I actually see a lot of the people that we work with that I call heroes. So
Mm,
sometimes there's a nurse hero or a physician hero, but child life specialists, I think, are angels, because these are people who are in the room. They're helping to distract. They're helping to support children who are having pain and or anxiety. And I have found, I don't know on your career, but I have found them invaluable
without
for
question.
and essential for the work that we do in pediatric emergency medicine on so many different levels.
Right. Yeah, I mean, I know our time may be escaping us, but the other case was basically just that. It was that I was going to share was a 6 or 7 year old male with autism spectrum disorder, pretty advanced disorder, who was largely nonverbal, who periodically throughout his life would grow averse to oral intake and would need to come in for IV fluids, and had done so on multiple occasions, and um, had grown more and more distressed by needle sticks, IV pokes, and we had recently sort of rolled out inhaled nitrous oxide, and we were like, well, we can try it. The mom was willing to try it, and we were able to utilize a wonderful child life specialist to kind of introduce the mask and paint some, scented flavor of sorts to help this sort of child receive the mask, and put stickers on the mask that he would use, and through, really, I think I'm just there. I mean, I'm really there just like pushing buttons on this nitrous oxide delivery flow meter, and the mom and the child life specialist are really running the show, and the kid does beautifully, getting an IV inserted on the first stick, and the mom is literally weeping tears of gratitude, and like she's not seen that before, and she had seen him have either paradoxical agitation or just freaking out from like a nasal dose of midazolam that had been tried before, and he'd spit out oral sedative anxiolytic type medicine before, and he'd been held down. And anyway, I think that was one episode, or one case that we got it right. And that's that's what I would say I would love to strive to reproduce in every scenario, right? Where we bring the expertise and the creativity, and we want to provide evidence-based care, but we also want to be willing to experiment within those bounds, to render compassion and to see our patients. Parental anxiety can certainly exacerbate the child's anxiety, and so it's a sort of treating the entirety of the caregiving team, as well as or the caregivers, mom, dad, grandparents, whoever might be present, And that involves time, and that involves, willingness to humble ourselves and seek their input, and what experiences have you had before, and how did this go, and where did we fail, and what are you worried about, and what, those kinds of things where we submit to their expertise, and we know what these medicines theoretically are going to do, and we know that it's just an IV, it's just a little simple poke of a needle,
Sure.
and they're deserving of that care, and so it's really gratifying when we can get it right, and I don't know that we always do. I think maybe we don't get it right plenty of times, but when we do, it's like really it's just a really rewarding feeling to serve patients and families in that regard.
Yeah, it's interesting because I think there are times, rarely, there are times when we have interactions with children and families that go poorly, and it's not the fault of the physician or the healthcare team. It's just the situation
Right.
and family frustration, parental mental illness, dynamics in the room that just create a difficult milieu for us to engage. But it feels like, getting back to the case, the first case, we've talked about this on the podcast, is that bidirectional communication between provider and families and the children is the essence of what we do in
Agreed.
healthcare, let alone
Right.
pediatric emergency medicine, et cetera. I still think the last remnant of what we do that will be most meaningful is the way that humans communicate with humans.
Yeah, that absolutely makes sense. In fact, I came into this work through history. Like I think while I am committed to the science of medicine, I think that a humanities background, and to be better as people, better citizens, better healthcare providers, better spouses, parents, and speak. Sometimes the med student gets it right. Sometimes it's the patient care technician, or the child life specialist, or the mom, or the who. It's not just because I'm the attending physician of record doesn't mean that I am the leader in terms of like a pinnacle place, right? I hope I will be the chief servant, and humble myself to be willing to listen to all those. And that's easy for me to say in a podcast conversation, and you don't see how I am in the emergency department at times when it's busy and when it's stressful, and like I'm certainly prone to fail in that as well. But I think you're right. Setting ourselves up as fellow humans trying to alleviate the suffering of those who come to us asking for help is really the crux of the work we do, and it's really, I think, the best of what we do. And I think that you speak to that very, very compellingly.
Well, honored to have you here. Quick shout out. Ben and I have not met. We met a little bit before this podcast to set it up, but um, we trained in, I guess, 6 or 7 years apart during our fellowships, but we trained at the same institution. So, quick shout out to Ben's and my mentors: Michelle Nichols, Kathy Monroe, Steve Baldwin, Pete Glazer, David Bernard. There's so many people at UAB that shaped me for who I am, and I assume shaped Ben for who you are, and feel very fortunate and blessed to have spent 3 amazing years in Birmingham, Alabama. Also, shout out to my co-fellows, including Don Arnold, who's now at Vanderbilt. Um, feel very, very, very fortunate to have trained there, and I feel very fortunate and honored to have you as a guest on the HUMED podcast.
Thank you so much. It really is a privilege to be here. Thanks so much.
So, for those of you who are joining for the first time or are new listeners, please hit subscribe wherever you get your podcast information. We're pretty prominent now on YouTube. Hoo-hoo. We have almost 26,000 subscribers on the YouTube channel, and we continue to grow and learn. And also, quick shout out to Ty King, our awesome editor, who's been my partner in crime in this journey. And I hope everyone has an awesome day. Ben, thanks for joining us.
Thank you, David. I really appreciate it.
Thanks for listening to HUMED with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.